Okay, so now, as we mentioned, we're gonna talk a bit more about data because to become or to continue to be an efficient advocate, we need reliable figures. We need to convince decision makers that our cause is relevant. And without figures, we cannot make them to understand the relevance of this cause, the relevance of taking this condition seriously. So without further ado, I'd like to get our two speakers, one from house. So Evie, she will pronounce her name because unfortunately I don't speak Greek. And Tom Robson from JDRF. So over to you guys.
I'll jump up first. And if you all promise not to come close to me, I'll take my mask off to make it easier to understand what I'm saying, because I have a thick Australian accent, which I apologise for. So bring it closer.
Yeah, perfect.
I'll try and be like a little shorter if I can. It's great to be here with you guys today, and I think that's a fantastic introduction in that data is incredibly powerful when it comes to persuading decision makers, or put simply, it's incredibly powerful when it comes to persuading the powerful. And I thought it might be interesting today to just get comfortable and work through an example together. So I want to show you briefly the T1D index. It's a joint collaboration. Let's see if I can get it up on the screen properly. Nope. What do you think, Bed? You'll come up and help out? So the T1D index is a joint collaboration between the IDF, ISPAD, Life for a Child, JDRF, and then we've also had about 50 people living with diabetes who've helped us craft this thing. So really it's a joint collaboration between the diabetes world. And the idea was to say, look, we need good data for advocacy, so how can we create it? And that's the work that we've done.
Yeah, I don't know why it's not showing.
You think it'll come up?
Yep.
Do you want to see if... Is it possible to... Well, that makes it look really easy. Thank you very much. So if you go to t1dindex.org, and if you get bored during my talk, you can go there now on your phones if you like. If you go there, this is the landing page. And the whole purpose of it is to give us data that's useful for advocacy. So if we scroll down, we're presented with a map of the world. Let's start with a country. Who'd like to put up a country to talk to? Yes?
Bahrain. That's a bit difficult to take on.
Sorry?
I'll spell it out. It's B-A-H.
No, I know how to spell Bahrain. Let me see if I can... Here we go, I've got a selector here. All right. So let's select it up there rather than from the map, because it's a little small to click on. Now, one of the things that we put in here, and this was a piece of advice from the 50 who helped us craft it, is there is often confronting content on the index. It is difficult. So I just want to flag that for everybody here. Please exercise caution when engaging with it and also when sharing it with others. One thing I've found is, because I've been doing this a while, I can just remember the first day when we saw some of these numbers and we all felt sick and we took the rest of the day off. You may feel the same if these are the first times you're seeing the numbers. And when you're advocating, others may feel the same. So it's important to have that sensitivity to the emotional reaction, because they're difficult truths that we're about to go through. We start with type 1 diabetes in Bahrain. And the estimate we've got here is 2,000 people living with type 1, 110 who should still be alive, and around 20 healthy years of life lost per person. So these are the estimates we've built. Now, how do we build them? The short version is it's a Markov chain Monte Carlo model with some machine learning submodels, fed by about 400 studies of type 1 diabetes going back to the 1890s. The slightly longer version is we each year estimate how many new cases there are, and then for people living with diabetes, how many complications, how many deaths, and we just update each year over and over and over again. I think the important thing to know for you is that we kept testing whether the numbers matched reality. You know, where there's good registry data, does it match reality? And the answer is it doesn't. It's off. It's off by about 6% on average. So it's, you know, it's not exact. These are estimates, but they're pretty good estimates, in short, which we have found, together with the fact that it's been published in the Lancet Diabetes and Endocrinology, that it's been endorsed by more than 100 senior decision makers around the world, that it's supported by IDF and ISPAD and JDRF, you know, significant diabetes organisations. We found this is enough to give the data some credibility when you talk to decision makers. I'm relaying these facts to you because your decision makers may ask those same questions. But here's our snapshot of Bahrain, and if we keep scrolling down, it starts to tell us a little bit more. So, you know, first thing it notes is that type 1 is growing rapidly and can affect anyone. So if we click Learn How, it suggests that, well, we estimate 1 in 66 families in Bahrain are affected by type 1. And you can actually click through time. So let's see, 1990, it was 1 in 157. And if we fast forward to 2040, 1 in 15, based on the current growth rates. So that's pretty powerful. And this number, this kind of how many families affected, yeah, that was something that actually came, it's not a standard number in epidemiology. People don't talk about families affected. Guess why we put this in here? It's because people with type 1 help create this thing. Profoundly shaped the epidemiology as a result. There's a lot of numbers in here that come purely out of lived experience. That's one of them. We've also got some data to help explain this. You can see here, in Bahrain, type 1 appears to be growing at 10.5% per year, compared with 8.2% for type 2. And there's more comparisons here, and we've picked conditions that are dangerous and chronic, in the sense that if you get good treatment, you can live a rich, full life, but if you don't, it becomes dangerous. And so we've got, you know, HIV, we've got asthma, we've got tuberculosis. You can see how much faster type 1 is growing compared to those other dangerous chronic conditions. So these first stats are here for essentially establishing, when you're talking to somebody, hey, this is important. You know, sit up and listen. So let's put this in the context of a visit with somebody. Who would you visit in Bahrain to talk to about type 1 diabetes or diabetes more broadly? If you were going to advocate, would it be what kind of senior decision maker would you be imagining?
Yeah, probably like an IDF member, I'd say, of the Ministry of Health. I don't think it's a very small country. We don't have a lot of parties that are necessarily very concerned with type 1.
Okay. So senior, whoever you can access in the Ministry of Health, someone senior. And what would be your ask of them at the end of the meeting, do you think?
I think the policies suck.
Yep.
Yeah.
Yeah? So like a review of policies, maybe get together a working group, a bigger group of powerful people in the ministry that you could talk to and tell them more about this? Something like that? Okay. So one thing you could consider doing is, you know, right in your opening there is to open with statistics like this, you know, that type 1 is affecting, you know, 1 in 66 families today, but by 2040 it might be 1 in 15. You know, that it's growing faster than other conditions. And then you might want to say, okay, well, having caught their attention, you might say, okay, well, let's go to why that matters. And one thing that surprised us in our work is just how dangerous type 1 diabetes can be around the world. And how much, you know, I think if you're living with type 1, you've had the experience, it's hard to explain the burden of the condition. There's so many ways that it steals time, minute by minute, as you're stealing away to, test and inject, hour by hour as you miss out on something, having to wait to exercise or something like that. You might lose a day to visiting a clinic and spending time there. Type 1 is a thief of time. And so one of the things we've tried to do here is add up all of that into one number. And so you can see here, this is the estimate for Bahrain, that the average 10-year-old in Bahrain enjoys 79 healthy years of life, but that if they develop type 1, they lose 20 of those healthy years. So that's not just a life expectancy thing, that's all of those ways that type 1 steals time. It includes, maybe you, later in life, if you develop some retinopathy, or you need some kidney treatments, or like all of these things right up. It includes the time spent each year visiting the doctor, the time spent each day. And if you add that up, we think it's about 20 years in Bahrain. And that's a significant burden. And if you're talking to someone in the Ministry of Health, you could then ask them the question: how does this compare to some of the other conditions in this country? And the answer is, it outweighs most. If you've got type 2, usually the lifetime impact is about 2 healthy years, 3, 4, depends on the treatment regimen. Liver cirrhosis, which is one of the most burdensome conditions on the planet, it's about 10 years over a lifetime. And it's because the reason for this is because people live with type 1 for almost their whole lives. And so the lifetime impact is really significant. So it's an important point to land, that sort of sense of comparison, because it helps us put it on the map as a really significant issue. Again, I'm still here in the attention-grabbing phase. How do we grab someone's attention? But it's not enough just to raise awareness, right? We want people to go somewhere. We want people to do something. So let's come down here to our estimates for Bahrain. Now, this is all... We've constructed these estimates for 201 countries around the world. And the estimates you see here are what happens if we change things, if we change the policies that's up. And so what you're seeing here is the model thinks that most people in Bahrain get diagnosed with type 1 diabetes. In some countries, that's the most important thing. So that doesn't seem to be the case here. It seems that the model's estimating that some people in Bahrain are perhaps not getting secure access to insulin or full access to test strips. And so for those people, the difference between having insulin and 4 strips a day and just sort of having not quite enough of that stuff, having it interrupted, missing out on a month's supply, maybe you're on premixed insulin, the difference between those two is about 25 years of healthy life. So the fact that this, the model suggests here that there's a group of people who maybe are missing out on that, and it's a big impact for them personally. But on average for all of Bahrain, it's about one healthy year that could be restored. And then we have access to pumps and CGMs. That looks like a big dividend. 6 healthy years could be added back to someone's life, to the average life in Bahrain if that became widely adopted. Accessible, available, affordable, and adopted, where doctors are actually prescribing it and people are actually using it and getting full value. And then there's the last here is prevention and cures, so full life can be restored. There's some therapies coming down the pipeline. It's going to be pretty exciting over the next few years, but we need those therapies to be finished research before we can get back the full number of years that type 1 steals from us. But that's going to happen. I think about my boss, Aaron Kowalski, who's the CEO of JDRF. When he was diagnosed with type 1, he was told he wouldn't live that long. And it's been 40, 50 years since then. And it's because research has improved. The therapies have improved every year. Every 12 months a researcher spends at their desks adds 6 months to the average life of a person living with type 1, or the average healthy years. So all those ways that type 1 steals time are given back. Which one would you be most interested to talk to this minister about, or this Yeah. Okay. Sorry. I understand.
Okay though, it's okay.
I understand.
But yeah, I think it's access to pumps. I would say, because like logistically, I mean, in terms of medical supplies, thankfully, I think we have the luxury to have governmental access. But it's the other things that accumulate, and it's all of these things together. I wouldn't pick one specifically, if you know what I mean.
I do. I do. Okay. Well, for the minute, let me click on pumps and CGMs just to see what extra information is available under that. And then I'll finish by showing you how you can actually look at some of the other things as well. But under pumps and CGMs, we can click on this and it talks about, we can restore 6 healthy years for the average person. And then there's just a little walkthrough here that, this is all stuff you guys know, but it can be helpful to walk others through. So without devices, the average person with type 1 diabetes spends around 18 days a year managing their condition. When you add up all the different things. Devices like pumps and CGMs reduce that burden. But they also reduce complications and extend lifespans. So the estimate here for Bahrain is that every time someone changes their sensor, like changes their sensor site, they add 40 hours to their life. Whether that be reduced time in management or reduced complications, all these different ways, but they add 40 hours to their life, every site change. And you can make that really real for somebody if you're meeting with them if you've got devices, pulling it out and saying, I have to change this twice a month, or however often you change it. Every time I change it, it adds this much time to my life. It's fantastic. It's, these are the ways that it's inconvenient. It's still not perfect, but these are the things it does for me. I have seen people do that to prime ministers, and I've seen those prime ministers turn around and spend $500 million in type 1 diabetes the next day. That sort of very personal demonstration, coupled with the data about the impact of it, is incredibly powerful. When it comes down to it, these guys have a lot of different things they can spend their money on, and a lot of good policies they can spend their money on. So when you talk to them, it's important to both persuade them that it's a good policy, so it's in that category, but then to put that personal element to it so that they select you from that category. That's the combination that's really effective. The last thing that's in here is, we prompt people to an impact. So please, yes.
Yeah, I think the emotional charge of those numbers is kind of a double-edged sword, because especially with advocacy, I think it has a lot of pressure on young people living with diabetes. At least to me, I always feel the need to kind of do something and go out of my way to advocate, kind of make the condition better and make people living with the condition better. So I don't know, even when using something like this and repeating those numbers, you're talking about yourself, you're talking about your country, and you'd go on and say, people die because of this and people die because of that. So I just think it should be used with a lot of caution. My heart is beating right now.
Yeah, yeah.
It's quite uncomfortable. And that's something I think every diabetic has thought about. How long am I going to live? Am I going to be okay? It's a huge contributor to your distress, and with the guilt associated if you mess up your blood sugar as well. So I think it's a bit of a double-edged sword, because it has a lot of emotional charge, right? You're going there and you're putting so much emotional charge to your message, and you're saying I need money, I need support, but at the same time this emotional charge then reflects back on you. You get what I'm saying?
Yep. Firstly, can I say thank you? I appreciate you sharing that with this group. I'm sure there's a lot of other people feel the same way. I see hands going up. Yes, third row there.
I just wanted to ask if you have some information about the psychological side that people with diabetes use, and how it takes the years of our lives also, because everyone talks about the medical side and everything, but the emotional side effects, because I feel it affects much more on me than the medicine side. That I'm done.
I hear. So the question was, do we have any data on the psychological side? Because that's a greater impact on me and a more present impact on me. Short answer is not yet. This is the first version of the index, and we published it using the medical data that was more freely available. We're working on being able to get better psychological data so that we can actually truly count all the ways that it's burdensome.
I want to add to that. I feel like the stress and it's one of the most things that causes the disease. This is what I feel, and it's the one that prevents us to be better, to take care better in a better way. So I do feel like it's a important thing to research.
Yeah, I really agree. I've actually I was up late last night reviewing proposals from different scientists about how we can actually properly count that in a sense, so that it can be included in the way that we talk about these things, and so that we can evaluate policies differently. For example, I was at a conference recently where there was a debate about whether analog insulins were better than human insulins, and everyone who's used them knows they're better. But a lot of the benefit is in quality of life, and there's no way to measure that at the moment. And so the conclusion of the debate and the conclusion of the science, frankly, at the moment is that human insulin is better, which is, I don't think many people who've used the two would say that. So I really agree. I think we've got to get some good ways to measure that. And if I can respond to you as well, I really agree. These, as I said, these are hard numbers. It's confronting and it's difficult. The first thing I want to say is take care of yourself. Diabetes advocacy is a long haul. Please take care of yourself. Allow yourself to feel those ways and feel those emotions. But also know that there's a lot of hope. Like this is not destiny. This is not how it's going to be. We're changing this. People who receive good quality care and fantastic support, we're seeing people with type 1 outliving the general populace and living healthier lives than the average person. That's the destiny. That's what we're shooting towards here. And I think that hope is really important to bear in mind. Certainly that's what, when I had to take a day off after hearing about this, that's what helped me come back and go, okay, this is not where we end up. And we've seen so much change. In the last 50 years, 50 years ago, if you developed type 1, you could barely expect to live 10, 15 years. That is not the case today. Everything's changed, and everything will change more, and there's so much momentum behind this, you guys. I have never seen so many funders and organizations doing brilliant work. The next 3 years are going to see a tidal wave across this planet as care improves and these numbers radically alter. So those two things, take care of yourself and remember the hope. There's a question at the back.
I would just like to know how accredited this data is globally and how it's recognized, and how do we reference this correctly to make sure that it is seen as valuable as it is.
So what was the first part of that question again?
So how accredited is this data? Like, is it recognizable globally? Is it taken seriously? Like, how do we reference this so that we can actually use the statistics?
Yep, great questions. So it was published in the Lancet, Diabetes and Endocrinology, in October, which is, the #1 journal for this sort of content. So you can cite it there, and that's the best place to cite it, I think. Yes, if you go to the menu and the About page, all of the source documents are here, including the Lancet paper. So you can just click on that and have access to it. In terms of its acceptance, I think 70% of people around the world live in a country where the two main key opinion leaders in diabetes in that country have endorsed this. And that's in large part a function of the fact that it's been produced by the IDF, the peak body for patient associations or diabetes groups, as well as ISPAD, the peak body for doctors who work in the space, as well as JDRF, this organisation that's funded close to $3 billion in medical research. And so our networks have come out in a significant way to say, yeah, these are good numbers. The last thing I'd say is they're not perfect. As I said, like we're off by 6% on average. And we're practicing open science. So you can see on the right-hand side, there's a little button to access the code. We're actually going to offer prizes early next year for people who improve on parts of the model and improve its accuracy, add features that we don't currently have. If you've got a brilliant idea, that would be a great time to engage with this. I hope that a number of you might even do exactly that.
Yeah, I'm really sorry, but we need to finish
Running out of time?
with Tom. Thanks a lot, Tom. And as you are saying, there are a lot of things to be happy about, but there are many things still that we need to do. That's why we are here. I think all of you are very interested in the Type 1D index. We are going to be having some online sessions next year, so probably we can organize something with Tom to continue addressing things and for you to show more of the platform to the young leaders.
And please feel free to reach out. I'm available on LinkedIn, all the usual social media. You should be able to find me. Or come grab me on the side. Tom Robinson.
We will be sending everyone the slides, so you will find his name in there as well.
Excellent. All right, thanks all.
Thank you, Tom. And now we're moving to my colleague Evie from the IDF team. There we go. And then I hope
Hello? No, it's okay. So I have to remove my mask as well because I have a Greek accent. I guess it's worse than Australian accent. So I had some slides, and I will go very fast because they will give them to you, so you can find all this information, because I want as well to show you how you can explore the data of the Atlas. IDF provides this data since, you see the Atlas edition since 2000, and early enough focused on that because we knew that data on diabetes empower people with diabetes, gives strong weapons to people that work for advocacy, for awareness, and even scientists. And this is the audience of the Atlas. Most of the audience of the Atlas are researchers, are policymakers, health ministries, because we need the diabetes numbers that unfortunately they're very sad, but on the other hand, it's a strong weapon on the hands of people that work for people with diabetes and for the people with diabetes. So I will go fast with the slides because I want you to see how you can find the data we have in the Atlas. So starting with the latest edition, I will just briefly show you, and this you can find them in the slides, what we have in the Atlas. We have diabetes prevalence, how many people have diabetes in the world. And because I don't want you to get confused and I want to distinguish between the index and the Atlas because it's important, in the Atlas we collect data of diabetes. And when I say diabetes, we don't distinguish when we collect the data type 1 or type 2. So the numbers we give are all types of diabetes. That means 80% type 2 diabetes and 20% type 1 diabetes. So if you want to focus specifically on type 1 diabetes, either you go on previous editions of the Atlas for previous numbers of type 1 diabetes, or to the type 1 diabetes index to have type 1 diabetes numbers for all the age groups, and you can also find trends on the type 1 diabetes index. If you go to the Atlas, you can use total diabetes numbers, and this is something good because it gives you big numbers, and big numbers move big heads. So use the big numbers, or depending on where are you focusing. Anyway, I will just show you what indicators we have. Another worrisome indicator is the undiagnosed diabetes. 50% of people in the world don't know they have diabetes. Diabetes incidence, how many new cases we have in every year. Of course, like I said, type 1 diabetes in children, adolescents, and adult onset, but this is also in the type 1 diabetes index. There is not only type 1 and type 2. There is pre-diabetes, people in high risk of developing diabetes, impaired glucose tolerance or impaired fasting glucose. Gestational diabetes, HIP, we call it hyperglycemia in pregnancy. And like it was similar numbers but differently expressed also by the type 1 diabetes index, is diabetes-related mortality, how many people lose their life because of diabetes. And diabetes-related healthcare expenditure, this is something that is important for driving policies. So Atlas is a tool for people with diabetes, for advocates, for scientists, So let's see how we find these tools. To mention that every edition of the Atlas, and sometimes that's why you can go to previous editions, I will show you why, there is related topics to diabetes. So the first list is what is core, is in every edition of the Atlas. But from edition to edition, we collect epidemiological data and we present a number, let's say, for diabetes complications, cardiovascular disease, kidney disease, diabetic food-related complications. So you can also find these data sets in the Atlas. So I will go straight to the website. This is the sources, and you can always get the slides and, you know, go through them analytically. But I want to use the time to show you the... So when we launched the Atlas, we launched the book. In the resources is the IDF Atlas. So you can download the book. It's the book that gives all the numbers. It gives maps. You can use the maps. You can download the maps. You can download the tables of diabetes per region, per country. So we give the book. We give the website that you can discover all kinds of information. We also have personal stories of people living with diabetes. And the most important is the resources. We have the book. We have the Atlas presentation. It's a PowerPoint that you can download and use the slides for your own talks or meeting somebody. So we provide tools. Previous editions, scientific publications that they are published every time we publish the Atlas, how to cite the Atlas, and other related copyright requests and studies. So let me go to the data portal, because I think nowadays people stop reading books, stop downloading the book. They want the data. So I live, let's say, like you said previously, in Bahrain, how many people have diabetes in Bahrain? How many people are dying for diabetes in Bahrain? How much money are spent on diabetes in Bahrain? So let's go straight to the data. When you go to the data portal, there is an intro that if you don't remember what I tell you today, it gives you a small orientation how to do the data, how to search for the data, how to download them. So you can go through that. So like all the world available data, usually we have a map. You can go and click on the map on the country of interest, or click it here, or by region. Before I go there, I want to tell you that because the Atlas, like I said, is not only diabetes, we give multiple indicators, because diabetes is not only type 1 or type 2. We give diabetes estimates, which now the diabetes we give is type 1 and type 2. We give mortality, impaired glucose tolerance, one type of prediabetes, type 1 estimates, hyperglycemia in pregnancy, health-related expenditure for diabetes, and mortality. I mentioned that? Yes. So these are, you can go there and find the total numbers for every country. So for example, if you go to mortality attributable to diabetes and click on it, deaths attributable to diabetes, you get the deaths attributable to diabetes for all the countries, starting always with the IDF regions. And what we did in the portal, because the Atlas runs from 2000, we think it's very important to show trends. So whenever it was available, we were putting the data from 2000, first edition, 2011, fifth edition, and 2021, which is the latest, the 10th edition. And not in all the indicators, let's say for mortality, not for diabetes, we have projections, what will happen in 2030 to 40. This is very important, because when you make your case, you're not only saying that right now 530 million people in the world have diabetes. There are going to be 750 million by 2040. So, you know, these numbers scare people, motivate people, so let's use of them. They're sad, but at least it's a powerful weapon. So let me go back to show you how to search. Again, you can go by region. So let's say I live in Greece, but I go to the Commission and I want to make my case. I can also go to the Europe region and see what's the numbers on the Europe region. So for example, I go to Europe, I click on Europe, and what appears in the data portal, the trends from 2000, people with diabetes, prevalence, so you know, you can even graph or download in this data, and I will show you why, for all the indicators. So in every page on the right side, there is a print, download, fact sheets, so it's a fact sheet that you can download especially for Europe. And this is in every page and every set of data you download. So let's search for a country, and I will say something. When I was pregnant with my first son, I had gestational diabetes. I didn't have a clue until then that, you know, that can happen. Nobody expects to happen to them, but yes. So at least, you know, you can go to the Atlas, Greece, I am Greek, and go to hyperglycemia in pregnancy. I hope there is, no, I didn't choose a good country. So maybe I am Greek, but I live in US. So let's go to United States. So at least I can bait the dual. That's the problem, you know, data are not always available for everywhere in the world. And I will use this example to say why it's important to have health surveys, why it's important to follow, you know, your doctor's appointments or be part of studies, because one of the biggest problems in the Atlas is that we don't have data for many countries. This is very sad because we have to extrapolate the countries, we have to calculate them for neighboring countries, and we don't have accurate data. So that's a problem. For example, for hyperglycemia in pregnancy, there is not enough studies for Greece. So somebody in Greece cannot know how many people have hyperglycemia in pregnancy and send a letter to the Ministry of Health and use numbers as a motivation to drive policies. So let's say United States. So let's say United States, I have gestational diabetes. I go and I see new hyperglycemia. Live births affected by hyperglycemia in pregnancy. 933,000 people in US have hyperglycemia in pregnancies, diabetes in pregnancy. 20% of the pregnancies. So these are strong numbers. You can write a letter to health ministry and say, like, you know, I have gestational diabetes. 900,000 people have gestational diabetes in my country. What are you doing for that? Do you have any programs? Do you have any trainings? How to manage my situation? Especially like in hyperglycemia in pregnancy, in most of the cases, the hyperglycemia can be managed by, you know, dietary restrictions and physical activity. So I can give more examples, and you know, you can give me your own example, your own condition, and how you want to find some data, and we can give some examples. We have still time to do that, so feel free. So what would you look for data for diabetes? What will, you know, concern you? Nobody?
Cost, because definitely this is what makes the decision makers more concerned about. So the cost attributed
The cost, okay.
to diabetes.
So like I said, you can either go by indicator. So on the left, you see the indicators, diabetes-related health expenditure, and discover the numbers. You can either find them in US dollars, in international dollar, which is an international way of expressing currency exchange, per person, and per person international. Let's say you don't want per person, you want total in US dollars. You can find them for all the countries available, and from 2011 to 2021, you know, also 10 years later, and per country and per region. But also here is the data. And like I said, in every case, you can go these tables and download the PDF or Excel file. You can graph your own data, print it. And these also, especially per country data, are also available in a map figure at the Atlas that you can download and use them. But let's say, for example, you can use per country. So I am from United States. I'm not from United States. I'll put Greece. Let's say I feel Greek, so Greece. And I want to see how much money are spent in Greece for people with diabetes. So here, diabetes-related healthcare expenditure, 1.273. So these are usually presented in thousands, and so 1,286,000 are spent in Greece dollars for people with diabetes. So these are numbers you can use, or you can use as trends. So this is the money that they're spent right now, how much they're going to be spent in 2030, in 10 years from now. And again, you can download them. You see here the graph, how this has been evolved, the people with diabetes since 2000. But you can also download your own data in an Excel and graph them yourself, or use data from the PDF of the Atlas or the PowerPoint presentation.
Hi. I have a
Yes.
question. I'm here. Ricardo from Portugal. Thank you for your presentation, but most of all, thank you for these initiatives. Both initiatives are, I believe, key aspects to digitalize diabetes and to show the power of technology when handling the treatment and how we can use this to improve the quality and, again, just improve the condition itself. I have a question here. So most of these data are both freely available data sets that are used in research, or data that is reported by the countries or by the IDF members. And these entities might not have the full data, because in some places people might be taking care of their diabetes, they are using products that are sold by the corporations, and corporations hold a lot of data. So at this point I have two sensors, but I have one sensor in my arm every day, tracking everything. And like me, there's millions of people. And my question is, how can we work together to try to open the loop on these proprietary softwares that collect data, and that would be a huge help to develop these indexes, these atlas, but we can't access now because they are still closed and they are still for the company side.
Yes.
So how can we create open healthcare in similar for initiatives like open banking, for example?
Yeah, I mean, this will be great. We have always taken into account, ethical committees and regulations in every country, because, these are private data and, not everybody is willing to share them. But what I can say that is very important, and IDF and many diabetes organizations are advocating for, are diabetes registries, that the data can be collected from doctors' offices, even from your devices. But yes, diabetes registries and the use of them is very important to collect data, to know the trends. Because, like I said, I think 30% of the countries in the atlas, they don't have data. We calculate the data from neighboring countries or countries with similar population. So I think the registries, collecting data from healthcare providers, and this is not a problem in high-income countries. We have to focus and give the tools and drive policies for low and middle-income countries, where there is the biggest gap of data, and for diabetes registries. But now the collaboration and to take the data from your devices, yes, that's something that I think it will be great, but it's very complicated. Even registries, the conditions and the health protocols, which we need them, because on the other hand, you don't want people to abuse personal information. So I think this will happen. Carefully has to happen from the devices, but it will take time. But let's start with the registries. Every diabetologist, endocrinologist, general doctor, to have a registry in their office that can collect their patient data, register them, and then this can be collected to a centralized data bank, nationwide, region-wide, or worldwide. That's actually the first step. And because we discussed that, I will take the advantage, because I have in my slides and I want to drive your attention. You can always come in the IDF booth the rest of the day today there and tomorrow, and we can discuss more. But there is another program of the diabetes, of the IDF, the type 2 diabetes and cardiorenal complications. Actually, we are promoting a registry that collects data of type 2 diabetes, and not only, or cardiovascular disease and kidney disease. And we are aiming mainly on low and middle income countries. So you can come and scan the code and take more information on that, or for the atlas. And also take advantage, is not here, but tomorrow there is a session at 8 o'clock at, I think, Auditorium 7 on IDF Atlas data, and the new data that we have recently published, and it's available at the website. We have Diabetes Atlas data reports newly published this year, actually launched this week. And it's, like I said, for related topics, like diabetes in indigenous people. Type 1 diabetes, actually, this is a report related to the type 1 diabetes index data. We selected some data and we're presenting them in a report. Diabetes, food-related complications, and COVID-19 and diabetes. So feel free to explore this new data in the website. Come to the booth to ask about it. I can give you more information, or you can go tomorrow to the session.
Hi, so I'm Sabina from Slovakia. Thank you for the presentation. I was wondering, when you are collecting the data, let's say about the cost, as you mentioned, do you get the resources or the data from the countries and the healthcare system, or pharma as well? Because what I was wondering, I know there are countries that are at a much worse state when it comes to healthcare, but right now it's like currently involving me as well when it comes to CGMs. Like most of them were not even in our market. Right now we have Dexcom, but it's covered by the healthcare insurance if we are paying for it. So I get only 1/4 of them, and I need to pay for the rest of them. So it's like, if you can afford it, you can have the benefits of CGMs, but the rest of the people, if you can't afford it, you will not get them. And the other CGMs are not even at the market.
Yes.
And it's partially covered. So whether you get the data, also like the coverage of the cost from the pharmas, what are they paying for? Or how much do the patients pay?
So yes, this goes more into the methodology of the atlas, which I didn't analyze it much, but I can talk about it further later. So the sources we are using, the data we're collecting, first of all, we have a team of 90 epidemiologists, experts in the field. So I am managing the project, I go through the data, but we have a strong team behind us that evaluates which sources, how to analyze the data, and this is a methodology developed the last 20 years and evolved from atlas to atlas. So it's very well picked up and analyzed. So the data sources we use, it's only from published data, published health surveys on diabetes. And I say published because when they're published, they are reviewed, so they are make sure they're good quality, from WHO-STEP surveys and from official national health surveys. So that's the only data that the Atlas is using. Now, specifically on healthcare expenditure, it's not so simple, the calculation, but the calculation is not based on pharmaceutical companies' expenses. It's based on how many people have diabetes, how much is the official country healthcare expenditure, and we do the calculation. This is the total healthcare expenditure in this country. The people with diabetes is 10%, so 10% of that goes to diabetes. So it's more simple calculation because it's more complicated and more, can take other factors in if you start taking pharma data and... So this is how it's in the Atlas now. Yeah. Simplified. But the methodology is also in the book of the Atlas, simplified methodology. So you can actually go there and see what data we're using. And you can always go to info@atlas.org, and I will reply to you. Yeah.
Thank you, Evie.
Yes, thank you.
Okay, so those were the type 1D index and the diabetes atlas. We were talking this morning. It's super important that you get information about what is happening with diabetes in your country, data that is reliable. That's going to help you developing your advocacy messages. We are going to be talking more about messaging this afternoon. But yeah, next year on the online sessions that we will have with the young leaders, we will learn more about that. So thank you, Tom. And thank you, Evie. And we're going to move to the next session now. Thank you, guys.